Good afternoon. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. For those of you that do not know me, we have 300 registrants today. I thought we had 200 yesterday, so we got a surge of people today. I'm so glad you could all join us to hear from Dr. Bose at MD Anderson in Texas. We have not had him speak with us or join us for any of these webinars or in-person events yet, but we're very, very happy to have him here with us today. You've met his colleagues before, Dr. Pomaraju and Dr. Verstosvik. And so today we're going to talk about JAK inhibitors because, of course, we have many that are in the pipeline, but also a couple that are about to be approved by the FDA and those that are already approved by the FDA and in use with our MPN patients. And so I will turn this over to Dr. Bose, and then we have plenty of time for your questions, some of which have come in already, but please send your questions to Mallory or to myself, and we will ask those. We have 1 hour with Dr. Bose. So Dr. Bose, thank you for joining us.
Thank you, Anne, for having me, and thank you all for listening. I hope you can hear me. This is probably the best I can do in my current setup, which is sort of a fixed desktop system here in the office. So as Anne said, we'll try to cover JAK inhibitors briefly, and then also maybe touch on some drugs that are not JAK inhibitors. So just by way of introduction, I am an associate professor in the Department of Leukemia here at MD Anderson in Houston. I work on MPNs, have been doing that since 2015, worked closely with Serge Verstosvik, who you all know. And I'm primarily a clinical trialist. I see a lot of patients with MPNs and run a lot of clinical trials. So I'll start at the beginning, and I think the key point is that MPNs are driven by the JAK-STAT pathway. It does not matter whether you have a JAK2 mutation, a CALR mutation, a MPL mutation, or none of these. But the JAK-STAT pathway has been shown to be universally activated in MPNs, and which is why the JAK inhibitors work regardless of the driver mutation. JAK2 mutation was discovered in 2005, CALR in 2013. So there was a bit of a lag there. MPL is fairly uncommon, but that was discovered in 2006. But again, regardless of the mutation, of the driver mutation, the drugs are expected to work because of the activated pathway. Now, of course, folks are most familiar with ruxolitinib. This is a JAK1, JAK2 inhibitor. And then hopefully around the corner is momelotinib, which is also a JAK1, JAK2 inhibitor, but additionally inhibits something called ACVR1. And ACVR1 is also known as ALK2, just in case it's confusing. If you see the different nomenclature, it's the same thing. And blocking ACVR1 or ALK2 leads to a reduction of the liver's production of something called hepcidin. And hepcidin is a key regulator of iron metabolism. And when you suppress hepcidin, what you do is that you make the iron more available to the bone marrow to produce red blood cells and less sequestered or trapped in the liver, spleen, etc. So it's a way of releasing iron for red blood cell production, and that is why momelotinib has this anemia benefit that it is best known for. Now, we also have fedratinib and pacritinib. So fedratinib was approved in 2019. This is a JAK2 inhibitor much more than it is JAK1. It also has some other targets, but not really very relevant to MPNs. I would say for MPN, from an MPN perspective, it is really a JAK2 inhibitor for the most part. This enjoys a fairly broad label from the FDA. It can be given to Anybody with myelofibrosis and over 50,000 platelets, they do not specify, having to fail, for instance, Jakafi or anything like that. It's a fairly broad label. Now, pacritinib is a little different. This got approved in 2022, February. Now, this is JAK2, so not JAK1 at all, actually, JAK2, in that sense, similar to fedratinib, but also an ACVR1 inhibitor, so similar to momelotinib in that regard, as well as an IRAK1 inhibitor. So it has got 3 targets, actually more, but 3 targets that we know are relevant to MPNs. So JAK2 and IRAK1 and ACVR1. So this drug has a fairly narrow label from the FDA, and it is for patients with myelofibrosis and platelets less than 50, regardless of line of therapy, but less than 50. However, if you look at the studies of pacritinib, it has very much been studied in patients with higher platelets. It's been studied in its pivotal trial in patients up to platelets of 100. And it has also been studied in other trials in patients with platelets above 100. So it is, however, I would say a drug that is preferentially active in patients with lower platelets. I think that is definitely a key attribute of this drug, and it fulfills an unmet need because ruxolitinib and fedratinib are difficult to dose when the platelets are low. In fact, when the platelets are less than 50, they cannot really be given at all. It's not that they are never given or they should never be given, but it's difficult because there are no data at all studying them in less than 50 platelets. And 50 to 100, at least with ruxolitinib, you have to employ a lower dose. So where pacritinib or even momelotinib come in is that you can dose them the same, regardless of the platelets or the hemoglobin, since they do not suppress the blood count. So that is where those drugs are a bit distinct. Now, fedratinib, going back to that for a moment, also does not require dose reductions. And as long as the platelets are above 50, you can use fedratinib at the full dose of 400 milligrams a day, but it has been less studied in patients with low platelets. So while technically you can use it at full dose in those patients with, as long as they are 50 and higher on the platelets, it's just been less studied. And I would say that it is more similar to ruxolitinib in the sense that it is better suited to patients with higher blood counts, whereas momelotinib and pacritinib are better suited to patients with lower blood counts. None of these things are completely exclusive of each other. There's always going to be quite a bit of overlap. For example, all these years when we did not have any other JAK inhibitors, of course, we used ruxolitinib in patients with lower counts. But the problems are well known. You have to dose reduce, you may have to stop and start. Anemia becomes a problem. Platelet count going down can be a problem. So it's a welcome addition or additions to see these new drugs sort of enter the arsenal, where you can tailor treatment a little bit better based on people's blood counts, as well as spleen size and things like that. Now, it's very hard to compare the four because, of course, there are not head-to-head trials. There is actually one head-to-head trial. It was called Simplify-1. It looked at ruxolitinib and momelotinib, and the two were about the same for spleen benefit, but ruxolitinib was better for symptoms, and momelotinib was better, of course, for anemia. So, but again, there's not a lot of data that we can fall back on to compare the drugs, but my overall perception is, again, this is a complicated topic, but sort of to summarize, is that ruxolitinib and fedratinib are great for patients with higher blood counts. What is meant by that? Well, 100 or more platelets, 10 or more hemoglobin, one could use as sort of benchmarks. And ruxolitinib, of course, never forget, has a survival advantage. So that's been shown, and that's actually been proven in multiple studies, including the original COMFORT trials. Now, going back to those days, since there were no other drugs, of course, the COMFORT-1 trial was able to compare it to placebo. And the COMFORT-2 was able to compare it to best available therapy, which was non-JAK inhibitors at the time. So, of course, I would agree that showing a survival benefit might have been a bit easier back in that era. And it is certainly possible that all of them have a survival benefit. But again, if you go by what's proven and out there, ruxolitinib is the one with the proven survival benefit. Now, pacritinib and momelotinib are, of course, much newer. And of course, they too have been in trials for a number of years. If you look at the total number of patients treated with pacritinib and momelotinib, they are a good 700-800 patients each across trials. But they are better suited, I would say, to the lower blood count patients. So I think the main takeaway from this that I would suggest is that momelotinib and pacritinib have the ability to be given at full dose, regardless of low blood counts. And that's important because with ruxolitinib, the benefits are dose dependent. So if you cannot give the full dose, you cannot expect the full benefit of ruxolitinib. And that is where I think I see momelotinib and pacritinib really making an impact. However, if one asks if blood counts are not an issue, which one is the most effective for spleen and symptoms? Again, we are sort of hamstrung by not having head-to-head comparisons. But I think the ruxolitinib data are probably the best, and fedratinib very close in terms of like frontline, good blood counts, patients who've been treated for spleen and symptoms. But again, as a lot of patients, especially as the disease progresses, will have lower blood counts, it's really important to have drugs that can address the needs of those patients. And that's where pacritinib and momelotinib, I think, are making or will make a significant impact. Now, not to make this too long, but I'll just touch on the non-JAK inhibitors, since there is growing interest in that area. So with the JAK inhibitors, what we always say is that they are great drugs in terms of making people feel better, shrinking the spleen, and taking away dramatically a lot of symptoms like night sweats, itching, bone pain, improving appetite, etc. And in fact, Claire Harrison says that one of her patients famously said, "This drug gave me my life back." So there is no doubt that the JAK inhibitors do that. The problem is that they don't really cure anyone. And, as you know, we still look to stem cell transplant for a cure. And generally speaking, they do not, in the trials to date, have that much of an impact on bone marrow fibrosis or the level of the mutated JAK2. For those of you who watch the allele burden or the variant allele frequency, those are not greatly impacted by JAK inhibitors, and that has been somewhat disappointing. The word disease modification is very much a buzzword, and it can be controversial because it is not uniform agreement on what it means. But generally, we all intuitively take disease modification to mean improving survival. At the end of the day, something that correlates with improved survival. So the thought is, although it's not proven, right? So that's important to remember. But most of us think that if the allele burden consistently goes down, bone marrow fibrosis gets better, the cytokines, which are these inflammatory chemicals, go down consistently. Those are perhaps indicative of disease modification. Now, do we know that for a fact? No. On the contrary, we know that if your spleen shrinks and you remain transfusion independent, those correlate with improved survival. So just putting in a plug for the traditional endpoints here. But there is nonetheless tremendous excitement about these newer endpoints and markers of so-called disease modification. So there are numerous drugs. It's certainly not time to go into all of them, but I'll just name a few that are pretty advanced in development and there's a lot of excitement about. So perhaps on the top of the list is perhaps pelabresib. This is a BET inhibitor. It's oral. There is also navitoclax. This is a BCL2 and BCL-XL inhibitor. So on the apoptosis pathway is where it works. BET, by the way, is an epigenetic protein. So that's an epigenetic drug. These two are in phase 3, large phase 3 pivotal confirmatory trials, or I should say registrational trials. And we are hoping to know by the end of this year what happens to those. Perhaps not as far ahead, but coming along is a drug called naftemadlin. This is an MDM2 inhibitor, which again is a way of unleashing the effects of P53. So MDM2 is a protein that restrains P53. So if you block it, you can have P53 do its thing, which is to kill the malignant cells. So this was big news at EHA this year in Frankfurt, Germany last month, sorry. So that's coming along, but we don't have phase 3 results from that yet. And then and I should clarify, that drug is being developed after JAK inhibitors. So in the so-called failure setting, after JAK inhibitor therapy, whereas the first two I mentioned, pelabresib and navitoclax, are being developed in the frontline JAK inhibitor partner sort of setting, because they are synergistic with ruxolitinib. And then maybe a word on imetelstat. This is a telomerase inhibitor. A lot of excitement recently in MDS, or myelodysplastic syndrome, coming along nicely in myelofibrosis as well. There was a hint of improved survival in a phase 2 study. And so this is also being trialed in the phase 3 setting, again in the JAK inhibitor failure setting, so after JAK inhibition. And also, last but not least, I mean, there are many drugs like this that I cannot really get into, but I will say that there is something to be said for anemia drugs. So I alluded to the anemia issue when I was discussing momelotinib and pacritinib, but remember that there are also drugs exclusively for anemia, like luspatercept, and there are others that are earlier in development. And these drugs could be nice partners for, say, ruxolitinib or fedratinib, which in and of themselves don't benefit anemia, in fact, may worsen anemia. So these drugs could be nice partners for those. So I think I'll stop there for now, because that's just sort of a high-level overview of many of the drugs in development.
Thank you so much. And that was so nicely explained. I really appreciate that, Dr. Bose. So we have many questions. Of course, many of our patients are on a JAK inhibitor. And the first question is, does Jakafi improve survival in addition to reducing symptom burden in intermediate secondary myelofibrosis?
So the question is quite specific. So if it is secondary, I assume we are being asked about post-PV, post-ET myelofibrosis. That's how I would interpret the term secondary. And then also intermediate was the question, right?
Yes, intermediate secondary, yeah.
So I think the most clean data for ruxolitinib improving survival is going back to the COMFORT trials, which were your patients with intermediate to and high risk, and then they all had platelets over 100. Okay, and there were a lot of secondary MF patients there. In fact, they had, I forget the exact percentages, but they had a good representation of secondary MF, which is post-PV and post-TT. Now, the tricky part is that there are many different prognostic models. And for example, the person asking the question used the term intermediate, whereas in the original scores, it was either intermediate 1 or intermediate 2. So I just want to sound a cautionary note that depending on which model you use, the terminology is different. There are numerous models now. The newer models certainly have intermediate, whereas the older ones have intermediate 1, intermediate 2, etc. So I will say that in general, yes, I believe it. I would say that yes, ruxolitinib does improve survival in most patients with myelofibrosis, but I think if you are looking for hard data, I think one would go back to the COMFORT trials, which are intermediate 2 and high and platelets over 100. But there's been many other data sets. However, granted, those are not randomized controlled trials.
Okay. Did Jakafi demonstrate an allele burden reduction in the MAGIC trial from 2022?
Yes, it did. So, so this is a great question. So the MAGIC trial is in PV. Of course, I've been talking about MF all this time, since there's so much going on there. But the MAGIC trial was in PV in patients who have failed quote unquote hydroxyurea, which could be resistance or intolerance, and they got ruxolitinib versus best available therapy. And this study had some striking findings. So one is, alluding to this point that the person asking the question raised, is about allele burden. So again, we have this notion that Rux is not that great in reducing allele burden, but in this trial, it was pretty good. It was significantly higher. The allele burden reduction was significantly higher in the Rux patients as opposed to the control. And importantly, that correlated, the reduction in allele burden correlated with improved myelofibrosis-free survival. So it essentially delayed the time to myelofibrosis progression. And also, while on that trial, it's important to mention that another criticism of ruxolitinib in PV had been that it has never been cleanly shown to reduce blood clots. But in this trial, they had an endpoint of thromboembolism-free survival, which is again time to a clot essentially, and that was significantly improved by ruxolitinib in the MAGIC trial.
Fantastic. Over the last few years, there have been a lot of conversations and trials with cocktails, of drugs. And so this question is, can any of the JAK inhibitors be taken with interferons or with additional JAK inhibitors?
So, I probably would not combine two JAK inhibitors. Again, I guess I guess there could be some potential if you could combine them in a way that one offsets the side effects of the other. For example, you could not combine ruxolitinib and fedratinib because they're both of them will greatly suppress the blood counts. But so yeah, that's a good theoretical question. I'm not aware of any studies, and I think what I would find more interesting is to combine JAK with non-JAK, as we were discussing. But to the first point, with interferon, yes, absolutely. So that has been done, again, mainly with ruxolitinib, because that's what people have been most familiar with and have had access to. And at least two trials that I know of, one is Jean-Jacques Kilagian in France, has done a trial called Ruxopeg in myelofibrosis. And previously from Denmark, Hans Hasselbach and colleagues have studied the combination in PV, ET, and MF, like as a, I think that might be called the combi study or something like that. But There has been those have been done, yes, and there do seem to be additional benefits.
You know that we have a cohort of young patients, pediatric patients, and we partnered with Dr. Cuisine at Weill Cornell. And we are, always looking at what's happening in the pediatric world. And this question is, are there any JAK inhibitors on the horizon for ET pediatric patients that you're aware of?
I'm afraid I'm not, but that may just reflect my lack of being in touch with the pediatric world. Nicole, again, is the best person, not that I have heard of.
Okay. And we will, Nicole will be with us in New York on September 22nd, and she will be talking about the studies that she's doing. So for that person, please, we'll keep you posted on that. Okay, so this question is, how are cytokines measured?
Cytokines are not measured in routine practice. So that would be, I would say would be quite unusual to do. But they are definitely measured in the context of clinical trials. There are specific assays that research labs have, but it's while it's not impossible, it would be unusual to check, say, in the course of routine practice, someone's IL-6 level or IL-8 level. Now, it can be done, and I say that because, for example, when you're treating something devastating like HLH, which is hemophagocytic lymphohistiocytosis, it's a horrible condition that is almost always fatal. Sometimes I have seen those cytokines measured in those settings, but in a regular MPN everyday practice, I don't think they are, they have a place yet. But absolutely in the context of trials, they can be done. You just need some special assays that typically your regular CLIA certified lab would not have. This would be a research lab.
Okay. Are you aware of any tests or trials that have specifically shown differences? We also do work and do have special programs for women, one of which will be in September in New York. And are there any tests that you're aware of that are relevant to the dosing issues perhaps in women? I know, for example, I'm a smaller woman, and sometimes I will take a medication that, everybody else is taking, but I have a strong affect, because of that. And are there any issues that you've seen, between like a Jakafi normal dose in a man or a woman?
Yes, and this is a phenomenal question.
Yeah.
Unfortunately, I don't have anything helpful to share. I'm not aware of any dosing guidelines, for example, that differ by, say, weight, gender, those types of factors. But I've actually seen, it's an anecdote, but I actually have a patient who has really had a lot of what one may consider disproportionately excessive side effects from a number of different therapies, not just a JAK inhibitor. And that might have to do with her being significantly underweight, and at least that's what she thinks. And that may well be true. It's just that sadly we don't have a way of being informed as to what to do, how to optimally dose. It's really shooting in the dark. For example, I remember giving her 300 of Hydrea instead of the usual 500, but there is no real method to this.
Right. So this is a great question, because very often, because we're in this world and have been in this space for so long and studying and living it every day, we forget that other people may not understand some of these terminologies. But what does allele burden mean?
Yeah, certainly. So allele burden is also known as VAF. You may hear that increasingly. Variant allele frequency. Sometimes it's even called mutant allele frequency. They're all referring to the same thing. So it really is simply the percentage of cells in the bone marrow that carry the mutation relative to all the cells. So it simply is that. They are just telling you what proportion of your bone marrow cells contain, for example, JAK2 or CALR or whatever you might be asking about. So it's just the percentage.
Okay, okay. And what would you say are the most promising drugs currently in clinical trials?
From this perspective or as a general question?
I would say, in general.
Okay, sure. So, well, I mean, and again, I presume this is about non-JAK inhibitors, because again, most of us believe that momelotinib is just around the corner and will be a welcome new addition to what we have today. So I would say that the most promising drugs based on what we know so far are one, I guess, pelabresib. This is the BET inhibitor. In combination with ruxolitinib, we've seen some really good responses, particularly in the front line, with 68% spleen response, 56% symptom response. So quite a bit higher than what we see with ruxolitinib alone. We've also seen some very interesting, what we think is synergistic effects on bone marrow fibrosis, on the essentially the marrow improving and becoming and going more towards normal. We've seen some interesting changes in the marrow. We've also seen the allele burden come down. So I think pelabresib comes first to mind. And then not far behind is navitoclax. I think I would say so. Again, very impressive results for spleen, for example, not so much for symptoms. That drug could have some difficulties with dosing when you give it with ruxolitinib because of its effect on platelets. So just some perhaps practical issues, a little bit more than with pelabresib, but also very interesting data on spleen, as well as those correlative markers like allele burden, bone marrow fibrosis, cytokines, those things. Now then, when we move on to this post-JAK setting, so not so much frontline combos, but post-JAK, what to do, because several groups have shown that the survival after you stop JAK inhibitors can be quite short, actually. So that is an area of unmet need, and several drugs are being developed there. So I would say the two most ahead or closest to the finish line there would be imetelstat and naftamadlin. So I was alluding to these earlier. They seem to have a survival benefit, which obviously remains to be proven in a phase 3 setting, but it certainly looks like there is from the phase 2s of both of these drugs. Naftamadlin is by mouth, imetelstat is IV. They work very differently. They are used alone at this point. They do have some toxicity issues. With imetelstat, there is a lot of some lowering of blood counts. With naftamadlin, there is that, as well as some gastrointestinal toxicity. But in these setting where we know the outcomes generally can be quite dismal, they seem to be making a difference there, and it remains to be proven in the phase 3s. And I always go back to this because it may not seem like a huge unmet need, but I think in reality, on an everyday practice level, anemia is still a big problem. It makes people not feel well, need transfusions. It's a burden on the patient and the healthcare system. And so we should also remember that there are some drugs specifically for anemia. So luspatercept is in phase 3. That's another drug in advanced development. There are some others. I alluded earlier in this program to ACVR1 and ALK2. So now some companies, example Insight, have their own ACVR1 ALK2, which could be inhibitor,
which could be combined with ruxolitinib. So I think anemia is its own thing, which also deserves attention and needs to be addressed on a practical level. But of course, the first one, the initial ones I mentioned, pelabresib, navitoclax, imetelstat, naftamadlin, these are all biologically targeted drugs that hopefully will alter the underlying disease.
So, which leads to my next question, and that is, how do you know what patient has what gene mutation? I mean, most, obviously the JAK2 gene mutation, but you mentioned other mutations and other targets for these drugs. So how will you know that? I mean, so how do you know what to best prescribe?
Sure, I think I do see the question. So yes, everyone, or well, not everyone, but about 90% have a driver mutation, right? So that's about, and again, we're mostly talking myelofibrosis here. So it's about 50 to 60% JAK2, 20 to 30% CALR, and then 5 to 10% MPL. And then there are about 10% who do not have an identified driver mutation. Now, it is commonplace nowadays, whether you're being treated at an academic center or in the community, for your physician to obtain what's called a myeloid mutation panel. This is generally an NGS, next generation sequencing based panel, and that'll tell you what mutations there are, both driver and non-driver. Now, one important distinction, and maybe it wasn't clear through the discussion, is that virtually none of the newer drugs that I mentioned, the non-JAK drugs, are tailored to a mutation. They're not. They are more general mechanism-based synergistic partners or even as single agents, but they do not generally rely on a mutation. The only exception I can think of is naftamadlin. You cannot use it if there is a TP53 mutation. That's the only exception I can think of. Otherwise, these newer ones are actually not mutation specific. Now, one area where there is considerable excitement developing is in targeting mutated CALR. So CALR has certain unique properties which make it easier to target through the immune system. So there are a number of approaches, including vaccines, antibodies for CALR mutant specific, MPNs. So that would be sort of the next frontier, I would say. Very, very early those trials are. Some of them are not even in trials, but most of the drugs I just discussed are not mutation specific.
Okay. Let's see, we've got so many questions here. So, we've heard a lot over the last several years about squamous cell skin cancers and the use of JAK inhibitors. And can you speak to that a little bit? With women, they are actually suffering vaginally. And I've actually known 3 or 4 women who have, over the years, I've been in the space a long time, but who actually did suffer from some really severe issues, but other skin cancers as well. Can you address that? I mean, as soon as you see that, do you switch inhibitors, or what is your approach to them?
So I think I can answer it only partially. I have not personally run into the vaginal issues with any of my patients, but the skin cancers for sure.
Yeah.
And so the thing is that it is our feeling or our notion that the skin cancers are a JAK1 effect. So remember I said that there is Jakafi, for example, as well as momelotinib. These are inhibitors of JAK1 and JAK2, whereas fedratinib and pacritinib are mostly JAK2 and not JAK1. So one could be tempted to think that if a patient is having problems with skin cancer problems with, say, ruxolitinib, let me switch them to fedratinib or pacritinib. And theoretically, it makes a lot of sense. I just want to sound the note of caution that it is completely unproven.
but it is the theory that JAK1 being more important in immunity. If you suppress JAK1, then you see more of the skin cancers, shingles, things like
Right.
that. So I think it would be nice to see data that fedratinib and pacritinib, let's say, don't have these problems. Remember, ruxolitinib is the oldest, so it has most of the data. So we just know the most about it. But you know, I have occasionally done this where someone's having you know, recurrent skin cancers. They're, you know, every week or every other week they're having something taken off. I mean, that gets concerning. And I have very occasionally, though, switched to something that is pure JAK2, you know, fedratinib or pacritinib.
All right, this question is from a PV patient. What is the thrombotic risk for PV patients, and any guidance or treatment guidelines to minimize risk at diagnosis? It's a good question.
The risk is overall low. It is overall low. The numbers are not that high, but of course, it is more than the age and sex matched population, right? So PV, of course, among the three classic MPNs, has the highest risk of thrombosis. But I just want to make the point that that absolute percentage is actually not that high. But I mean, I don't want to misspeak here, and this is something one can go back and look at. But it might be relatively small in the single digits percentage wise per year. You know, so it's not a very high risk. But of course, cumulatively over time, it is definitely you know, an important and significant risk. So. I wasn't exactly certain about what was being asked with the at diagnosis phrase. So, of course, PV patients can show up with a clot. I mean, there's a good percentage of PV that is diagnosed because of a clot. That's how it comes to light. But of course, over time, it's a disease in which people fortunately live many years, decades, in fact, depending on what age they start with it. And you can see you know, that risk over time. So it's definitely there. And this is why, you know, traditionally, we've had this concept of high risk and low risk, with high risk being over 60 years of age and or having had a prior blood clot, and low risk being younger than 60 and not having had a clot. But that is, you know, I think as we get better drugs, you know, now with this new data on Jakafi that we discussed in the context of the MAGIC question, and then your Ropeg interferon alpha 2b, which is Besrimi, which was approved in 2021 in the US for PV. I think we are actually seeing drugs that may have more of a biologic effect than, say, just was possible with hydroxyurea. And I think the paradigm in PV is starting to shift. You know, with low risk PV, we used to say, just watch, phlebotomy, aspirin, and no drugs. But that's partly because we didn't have anything other than hydroxyurea. Now, as we have interferons, and actually Professor Barbui has shown with Ropeg, the Besrimi drug that I was just talking about, that even in low risk PV, it makes a difference. To do that versus just phlebotomy.
Right.
So I think the paradigm is shifting. The overall risks are not that high in absolute numbers, but definitely you want to reduce them. And so I think we're in the middle of a change in how we approach PV.
This is from patient's husband, who says his wife has developed MF about 5 years ago and recently started Jakafi. And it's really helped with her constitutional symptoms and her counts. However, one side effect is weight gain. Yeah. And she doesn't know how to combat that. And if you have any suggestions, could she change treatments? Could, you know, is there anything else? Are you seeing that? We hear that quite often. And so I'm not sure what advice, you would give a patient.
Well, I definitely see that as well, and it's one of the more common side effects with ruxolitinib. It is unavoidable with ruxolitinib. It is just going to happen with, at least in the context of that drug. The average, I believe, is like 4 kilograms. But again, that can be substantial. That's about 9 pounds. And it does level off. Usually, one doesn't keep gaining weight. Although I have heard that too, but that's just one patient. I have heard that story, which is really striking. But generally, it levels off. It plateaus. Now, is that better with fedratinib, pacritinib, momelotinib? I don't know for sure. I will say that I have not heard of it as being an issue with those. But is that just a function of having shorter follow-up on those than ruxolitinib? I'm really not certain. But it is, it's a point worth making that at least thus far, I haven't come across it as being as much of a problem with the newer JAK inhibitors.
Mhm.
I think we don't know the last word on this story, but so far it's a ruxolitinib issue for the most part.
This patient is starting to have constitutional symptoms again after being on Jakafi for a while. And is that an indicator that they should switch inhibitors or, change medications or change their protocol?
So symptoms are definitely a part of the whole picture, and and obviously are important as they determine quality of life. And certainly one could have disease progression that manifests as symptoms.
Mhm.
But I think the decision regarding switching or maybe keeping the Jakafi and adding something if the patient has access to a clinical trial will depend on what is Jakafi doing otherwise. So let's say the symptoms are worse, as we just heard, but the spleen is nicely down and the counts are stable. Well, then you may want to keep Jakafi and maybe look for a clinical trial to add another drug, perhaps for the symptoms. But there could be also a situation where it's really starting to fail. I mean, the spleen is growing as well, the counts are going down, symptoms are getting worse. Well, then sure, one could switch.
Okay. So do you track the clonality of MPNs with your patients?
No, not usually, because we don't know what to do with the data. I mean, you can certainly check an allele burden over time, but as I was saying earlier during the call, we just don't know what that really means, because obviously when it goes down consistently, that feels good to everybody, to the doctor and the patient. But if it starts to go up, we don't know necessarily that correlates, I mean, frankly, up or down. The problem is that outside of the MAGIC trial that we were just discussing in PV, where if your JAK2 went down, that correlated with a delayed progression to myelofibrosis. Other than things like that, data sets like that, we don't have any good sense of what this lowering or increase in the JAK2 allele burden means. So it can be scary to a patient if it's going up. I think that cannot be overemphasized. I mean, if you don't know what to do with the data, do you really want to know? I think there's something to be said for that. So no, we don't routinely check.
So I know Dr. Wadley many years ago, Martha Wadley, and now Angela Fleischman have been doing familial studies, and I think Brady Stein also, but so if I were an MPN patient, should I have my family, my siblings, or my children checked for gene mutations?
So of course, MPNs can run in families, and you don't generally pass along the mutation itself, okay, like the JAK2 V617F, you don't usually pass that down or inherit that, but you may inherit or pass down a tendency, a genetic predilection to acquiring that mutation. And that definitely happens. Many MPN families have been described, but I don't think we are at a point where anyone with an MPN should start to worry that, let me get everyone tested. And I don't think we're at that point. I don't think it's that common.
Mhm.
So my answer would be no.
Okay. Is it safe to fly after receiving a phlebotomy? I remember years ago, PV patients saying, that they had some issues flying.
Interesting. Not that I have come across. I would have said no. I don't. I haven't come across that. And here at MD Anderson, many of our patients do actually fly to their appointments there, since they come from all over. So I have not come across that. And one could get a little dehydrated, but again, I don't think that should necessarily cause a problem flying.
Okay. This patient is a triple negative and on anagrelide. Would that person be better off taking one of the newer drugs at this point? Because, that was like hydroxyurea, anagrelide, those drugs seem to be, from the old school, although I know anagrelide does help with some thrombotic issues and so on.
Yeah, anagrelide does a good job in lowering the platelets. That's about it. Now, the problem in ET is that the platelet count actually does not correlate with the thrombotic risk very much.
Okay.
If it is super high, it predicts for bleeding, but it doesn't really correlate with clotting risk. So anagrelide is not really I would say most of us don't use much anagrelide.
Yeah.
It is typical to start with Hydrea if the patient at all needs cytoreduction. That's usually frontline. Unfortunately, Jakafi is not approved for ET and therefore may be hard to get. But interferons would be my go-to after Hydrea rather than anagrelide. And also if the patient is young, which again obviously doesn't have a definition, but I mean certainly less than 40, maybe less than 50. I would lean towards even starting with interferon, because with Hydrea, there are these long-term unknowns about Hydrea's effects on, because it's a cytotoxic drug, its effects on genotoxicity and all are unknown, and therefore we shy away from that a little bit in young patients who may be on it for many decades, and I do use Jakafi, even though it's not approved. I do use Jakafi in people who are, say, have failed both hydroxyurea and interferon, maybe even anagrelide. But anagrelide, I will point out, I don't think it does a whole lot. It's mainly lowers the platelet count, which is of questionable importance. It depends on the patient's circumstances, of course.
Right. And actually, I misspoke, because I do know several patients who have had heart attacks and have had issues on anagrelide. And I agree with what you said. We are very close to 2:00. And so I would just like to thank you very, very much for being with us today. The last thing I ask all of our physicians that join us is, what words or wisdom, can you impart to our patients that are on this webinar for the future? I mean, it seems incredibly hopeful to me. From your perspective, if you could share that, that would be great.
No, I think it is, for me, it's been it's been remarkable to witness, the kind of progress there has been in these last several years. When I think started in the field in 2015, there still wasn't that much, right? I mean, even fedratinib approval came in 2019, Ropeg in 2021.
at least in the US. So I think we're in a whole different era with drug development for sure. And this enormous interest. There is, today we just talked about some of the big hitters, but there are so many other drugs in the pipeline, early phase, new targets being discussed all the time, the biology getting elucidated all the time. So I think it's definitely very exciting to be an MPN researcher at this time. But for patients, I think there's a lot coming down the pike. There's a lot to look forward to. I think organizations like yours really help in connecting people and sort of, getting some of the questions like I answered today answered. I would say that again, overall MPNs are rare, right? So I think it's important that you seek out information from people who are relatively familiar with this. And I mean, obviously, no offense at all, but when you are a general hematologist oncologist, this necessarily becomes a small part of your practice, and it is good to maybe have somebody at a center of excellence or expertise in the loop with
Yeah.
your.
Yes, we always encourage our patients if they're able. It depends on their insurance and their, a lot of logistics go with that. But that's why we're so grateful to you and to our other MPN docs and researchers who are always available to us and to our patients. And but we do encourage those who are diagnosed with an MPN, if they can see an MPN specialist, that's always, wonderful. But we can also make sure you bring the correct information to whomever you are seeing if you're unable to go to a major institution. So with that, I'd like to thank you very much, Dr. Bose. I hope to see you again, perhaps sooner rather than later. And to all of those who are with us, I want to thank our partners, our industry partners who make these possible. They make all of our programs possible and our in-person events. We have 2 events coming up next week. On Thursday, the 13th, Justin Grinnell will be hosting an exercise program for MPN patients from 12 to 12:30. And then Natalie Giacondo will be hosting a program for MPN patients for yoga and mindfulness. And that will be from 12:30 to 1. Then in September, September 22nd, we'll be in New York City for the 9th annual Women in MPN program. So please join us. I hope you learned something today. I did. I always do. And thank you so very much, Dr. Bose.
You're welcome, man. Thanks for having me.
Thank you. Have a good day.